welcome to Inpatient Update. I'm your host, Mason Turner, and this is your podcast for practice-changing evidence for the working hospitalist. Today on the show, I'm joined by Dr. Andres Ospina as we discuss aspirin combined with anticoagulation in patients with coronary artery disease and duration of IV antibiotics in bacteremia. A reminder of the format, we'll have a conversation on 2 recent practice-changing articles in less time than it takes you to finish your morning cup of coffee. Well, Andres, thanks for joining me.
Well, Dr. Turner, thank you for having me. It's quite a treat and a privilege. So I really appreciate the opportunity to be here.
Thank you for taking the time. Of note, if you don't mind me sharing, we're both in a similar personal boat of that anxious period awaiting a new child, and I think we're maybe both using this podcast recording a little bit to take our minds off and fill our time when from other things that could be happening now as we wait on the inbound newborn stage.
That's exactly right. Exciting times, but also a little nerve-wracking. So I'm just glad to have these articles at hand, maybe as a little bit of a distraction, if you will.
All right, certainly. Dr. Ospina is one of my excellent colleagues, is also a hospitalist working at my institution with me, and is clinically excellent. Anything else you think the listeners should know about you, Dr. Ospina?
I don't know about clinically excellent, but I try.
That is clear. That is clear. He definitely does try. All right. Well, let's get right into it. Dr. Ospina, I'm sure you've a lot of times had these patients like I have who have a history of coronary artery disease. They're on aspirin. And then I just recently had a patient who was maybe a 70-ish year old woman, came in for surgery, was on aspirin, and then had some post-op AFib, and we started anticoagulation. And previously, honestly, I just start the anticoagulation and don't even think twice. Well, I think twice, but had done little pause of what should I be doing with the aspirin. But there was a recent study released in just October of last year that addressed just that. So this was the AQUATIC Trial, an article titled Aspirin in Patients with Chronic Coronary Syndrome Receiving Oral Anticoagulation. And it was in the New England Journal of Medicine in October of 2025. So this was a multi-center, double-blind, randomized, placebo-controlled trial that had 872 patients randomized to either get anticoagulation alone or anticoagulation plus aspirin. And these were patients that had a history of coronary artery disease with a CABG or PCI that was more than 6 months ago, and then had a reason to start anticoagulation. And so what this study looked at was a composite outcome, sort of your kind of a typical composite outcome: cardiovascular death, heart attack, stroke, need for coronary revascularization. They included acute limb ischemia. So they comparing aspirin to aspirin plus anticoagulation in this patient group that has a history of coronary artery disease on aspirin for secondary prevention. And they found that the hazard ratio was 1.53 for increase in the composite outcome in folks that got both the anticoagulation and the aspirin together. So that was about 17% of those folks getting both, compared to 12% getting anticoagulation alone, obviously with a placebo, saying it was placebo controlled. They looked at a few other outcomes as well as secondary analysis. They looked at death from any cause, was also higher in the aspirin plus anticoagulation group. And then they looked at major bleeding, and that was 10% in the aspirin plus anticoagulation group compared to 3.4% in the anticoagulation alone group. And that had an adjusted hazard ratio of 3.35 that was statistically significant, obviously from those numbers, pretty significant. So all that is to say, the headline is obviously these patients that have, you know, had a PCI 1, 2, 3, whatever, more than 6 months ago, who now have new onset AFib or a DVT or whatever and need anticoagulation, they do better if you stop the aspirin. So for my lady I kind of referenced at the top, I actually, um, like I said, recently taken care of her, and this was recent enough that I had read this article. And specifically for her, I talked with the team. I was co-managing the patient. I talked with the team. I said, "Hey, let's stop the aspirin and her and do Eliquis alone for her AFib plus remote history of coronary artery disease." Um, so, what do you think, Dr. Ospina? Something you're going to use in your practice? Something you're not going to use? Any thoughts?
No, I mean, certainly, truth be told, before you sent me this article, I wasn't aware of this particular trial. And then even full disclosure, my wife is a cardiology fellow, and so she immediately knew about what I was talking about, or referring to this article. But I think what was interesting to me, and just much like you pointed out, like this article specifically kind of focused on high risk patients, really with prior stents, and I think a large proportion of these patients, greater than 70 or somewhere around there, had prior MIs. I think that they also mentioned, I think the AFIRE article or trial in kind of the discussion for this trial. And interestingly enough, when you look back at particularly at that trial, one of the things that this study I think did well was that while apixaban was the kind of more prevalent choice of anticoagulation, it really was not just sole type, right? It also kind of included rivaroxaban and dabigatran and warfarin particularly. Um, and so I think very applicable. I think, like just like you said, I think perioperatively, whether we're co-management or consults, and then patients just really coming in for any reason, whether it's a new embolus of some sort, or a new thromboembolic event, that do happen to be on aspirin for coronary disease. I think very, very much so pertinent. And I think one of the pitfalls, if I'm being honest about it, is when I've encountered these situations in the past, is more better, is keeping them on aspirin better, because they are high risk. And I've done that, and to the point where, okay, we're starting anticoagulation. Well, I'll leave them on aspirin and have them follow up with a cardiologist or whatever the case may be. And I feel like that this is enough evidence, particularly even in such a high risk population, which we oftentimes see, to tell me that not really, that aspirin needs to be peeled off. And so certainly something that makes me change my perspective on it, and certainly something that's applicable probably day to day, depending on kind of who we're seeing.
Yeah, to your point, patients will ask this a lot when I start them on an anticoagulation in this setting, and they're like, "Oh, no, I already taken aspirin for anticoagulation," or probably more often if they're on DAPT and they're on Plavix or something else. And I'll be standing there telling them about like antiplatelet being different than anticoagulation, and you still want that antiplatelet effect, and yada yada yada. And and this is telling us that that's not true, and not that it's not true from a pathophys standpoint, but looking at the study, the fact that they looked at major bleeding as a subgroup, and that's where you see such a big difference. It's pretty clear to me from these numbers and just logically that the difference was that the aspirin plus anticoagulation people bled more, and therefore they had more MI and cardiovascular death and everything else because they were bleeding. It seems obviously like that was the major driver here, which makes sense. Um, when I was early in training, it felt like we gave aspirin to almost everyone for primary prevention. We'd calculate their ASCVD score, and like everyone would be kind of high, and we were throwing people on aspirin. And I distinctly remember sitting in an auditorium with one of my co-residents who was going into cardiology, and kind of like your situation with your wife, he was more up to date on the literature in that. And he's like, yeah, basically don't do aspirin for primary prevention anymore. And then it feels like similarly with this trial, we're kind of walking back and narrowing what we cover aspirin with. I mean, it's super exciting that aspirin, this cheap drug, is so powerful that it can prevent heart attacks. But I like that we're going in to more studies on this cheap drug. Like, I'm surprised we get the funding for these studies, honestly, because it doesn't seem like there'd be a pharma motivation to do these studies. But we're really figuring out who does it exactly help, and we've kind of narrowed that down over time.
Yeah, I agree, and I think it's just interesting too with the concomitant use of the DOACs. It's just the paradigm has really changed since I was in training, since you were in training, and it's seemingly in short amount of time. And I know that part of my first instinct, and I don't know if this is right or wrong, was the article that they had mentioned, the AFIRE looking at rivaroxaban. Well, the teaching conventionally in residency had always been, well, when you compare head-to-head Eliquis and rivaroxaban, the higher incidences of bleeding with rivaroxaban comparatively. And so is that part of why in that other trial we were, it stopped early, or how rivaroxaban plays into it? But I agree. I think that it's just all changed so much, and I'm very, very interested in the fact that we're studying this and the combination therapy for all these patients that are high risk.
One of our colleagues recently asked me if I could be any drug, what would it be? And I answered kind of aspirationally. And I said aspirin because I think it's so cool that it's cheap but so powerful. I was actually listening to a podcast recently talking about repurposing medicines, and talked about how for secondary prevention it's got a 25% reduction in heart attacks. And so, like, this cheap drug that's been around forever, that comes from plants, that we've used for pain control for forever, like, has such a massive effect on reducing the risk of heart attacks. It's just super cool to me. Um, but maybe I should walk that back. It's becoming less and less used in that setting, at least.
Yeah, maybe you should have picked a Pixaban. I'm not sure.
Yeah, maybe so. All right. You ready to move on to our next study?
Yeah, we'll move on to the next study. So I guess I'll go ahead and jump right into it. As you kind of alluded earlier, this article is now, or this trial now referred to as the BALANCE trial. I think this came out kind of November of 2024, if I'm not wrong. But this was a trial published in the New England Journal of Medicine, looking at antibiotic treatment, particularly in patients with bloodstream infections, and really a head-to-head kind of somewhat comparison of 7-day treatment versus 14 days. It was a multi-center randomized non-inferiority trial. It was based across 3 different countries: Canada, Australia, and New Zealand. It looked at just over 3,600 hospitalized patients, meaning adults, with bloodstream infections. The predetermined non-inferiority margin was 4%. An absolute difference in 90-day mortality. I think previously some of the infectious disease studies had kind of targeted 10% margin, but they were being even more strict in this study. The population was really hospitalized adults with confirmed bloodstream infections. Interestingly enough, a high proportion of the population in this study, approximately 55%, were ICU patients at time of diagnosis. And actually, this was where it was piloted before being brought on to patients that were kind of in the wards, if you will. The bacteremias had all different sources of origin, about 42% urinary tract, 18 to 19% kind of abdomen, 13% pulmonary, and then vascular catheters and skin and soft tissue infections accounted for about 5%, respectively, of all bacteremias. Interestingly, when you break it down to organisms, most cultures were positive for monomicrobial gram-negative rods, about 71%. Monomicrobial gram-positive cocci were roughly 17% of the makeup, and 11% of patients had polymicrobial bacterial infections. There was a little bit of a stringent exclusion criteria, particularly as it relates to kind of, certain severe, or what we consider severe, bugs or microbes. Staph aureus was excluded. Staph lug was also excluded. Fungemia was excluded, and other rare bacteremias that required kind of prolonged therapy. Patients that had prosthetic valves, endografts, or any sort of syndrome that we know required prolonged IV antibiotic therapy, including endocarditis, osteomyelitis, and that nature, were excluded. And lastly, severely immunocompromised patients, actually including solid organ transplants on active immunosuppression and severe neutropenia, were excluded. really the comparison of the intervention was the 7-day total of antibiotic therapy group as compared to the control, which was the 14-day total group. And they were looking at really a primary outcome of death at any cause or of any cause at 90 days after diagnosis. And interestingly enough, what the result suggests is that at 7 days, looking at the primary outcome, again, death at any cause, that was about 14.5% of patients compared to 16.1% in the control 14-day group. It's really a net absolute difference, negative 1.6% when you look at it, which of course met that already kind of stringent criteria, non-inferiority criteria, 4% margin. And even so, what this article kind of suggests is that secondary outcomes looking at hospital mortality, relapse of bacteremia, really no significant difference. Length of stay were actually fairly similar. And of course, in the 7-day strategy, antibiotic free days at 28 days after diagnosis was lower. Just some context too, this was, I think, the largest and has been the largest randomized controlled trial in bacteremia to date, approximately 5 to 6 times larger than any other trials. I love that it included a substantial ICU population. Like I mentioned earlier, this was where it was piloted, so I think that makes it more applicable. But we'll just I'll leave my my commentary for a little later. And then, interestingly, too, it was kind of the most heterogeneous. It had multiple sources of infections and pathogens, and adequately powered. So really, the bottom line is, in hospitalized patients or hospitalized adults with uncomplicated bloodstream infections, including those that have been in the ICU, 7 days of antibiotic treatment was non-inferior to 14 days with respect to death by the 90-day mark after the diagnosis. And so, Dr. Turner, truthfully, when I review these types of studies or non-inferiority, I kind of have to remind myself what that really means, just because but really, what it's saying is that we are statistically confident that the short course, meaning the 7-day course, is not meaningfully worse than the 14-day course. Really is not proving that one is better or wrong compared to the other. But anyway, for me, I think again, when you extrapolate it and think about how applicable it is for a day-to-day hospitalist, I think I focus on, I think one, yes, it is very applicable. I think we see a lot of ICU transfers, people coming in and out of the ICU. I think infection and bacteremia is exceedingly common in the hospital. I think takeaways for me is kind of, being mindful of what this uncomplicated bacteremia is, or how you view it, right? And really, it's just kind of based on the exclusion criteria, making sure that the host has no severe immunocompromised states, really targeting on the bug. Of course, no syndromes, no endocarditis of the sort, but with source control and with appropriate antibiotic therapy, I think that it's very, very insightful, and I think will help me in the long run. I think it's, from what I'm gathering here, and I would love to get your thoughts on this, most beneficial to me as a day-to-day guy when it comes to the urinary and intra-abdominal infections. I think
Sure.
those by far are common. People that are patients that come in with pyelonephritis and bacteremia, E. coli, right? It's kind of a common scenario that I see where I'm giving 10 to 14 sometimes, and
Hmm.
it's, there's evidence here now.
I agree. Yeah, huge, right? The 7 days being just as good as 14 days. I mean, massive difference. And really, I think the biggest thing is going to be who goes home with a pick and who do we finish in the hospital. Um, but yeah, I mean, super cool, huge. For gram negative, I feel like I've already been hearing, and I don't know if it came from this, but if, for gram negative bacteremia, we're already like treating with shorter courses. I mean, the exciting thing is the gram positive portion of this for sure. When I first saw the headline, I was like, awesome. Like all these people with, you just like see it and you're so excited. And I'm like, everyone who's got, you know, IV drug users with endocarditis and stuck on antibiotics forever, we're cutting down durations and all of that. And like, obviously, like that's way, way out of the scope of this. And like, very appropriately, like that wouldn't really change that practice. And then the exclusion of Staph aureus is obviously huge because I mean, our non-gram negative, gram positive bacteremia that we're treating people for, like Staph aureus is a big one. But like our Ephesium, Ephecalis bacteremias and all of that kind of stuff, this is going to cut it down. It'll be interesting to see what, if any, difference this makes on our hospital length of stay. I often feel with my gram negative bacteremia patients that I'm already trying to treat with a shorter course that you get to that point where by the time you know what's going on and you've treated them with IV antibiotics and they're getting better, you're like, I'm so close to 7 days. Like, does it make sense to put a pick in this person for 48 hours of home IV antibiotics, coordinate with a home health agency and all of that? Or do I just, or maybe you get by with Cipro and you can treat them with something oral. But, or does it just make more sense to complete this course in the hospital? And I don't know where I'm going to land on my patients, like I'm saying with the Ephecalis, Ephesium bacteremia that are in the hospital. I can get by with 7 days, and you're getting to that. By the time you've, I didn't look to see if they do anything on whether or not you clear cultures, but I mean, I'm still for gram-positive bacteremia going to be wanting for them to clear cultures. So by the time you've hit that mark, where they had the initial bacteremia and then they have cleared cultures at 48 hours on repeat after therapy, you're basically 7 days. So you're saving people from going home with a pick, but you're maybe, I could see myself hanging on to a patient for an extra day to complete their 7 days rather than like who I would have sent home with a pick for 2 weeks of IV antibiotics previously.
No, I mean 100%, and I think to your point, that's exactly right. The the other thing that yeah, where I'm going to land on this is it's hard to know. I think it just depends on really the host as well. Like, what am I seeing on a how well is this patient doing, and kind of your clinical just saw in a way. But I think that you're exactly right. I don't know what the average length of stay for gram-positive bacteremia is, presumably non-staph, but I think if it's a week, you're right. By the time you have the workup, by the time you have repeat cultures, by the time patient's improving, you're really theoretically at least at the 5 day mark, if not close to that 7 day mark. And I think for me personally, as a kind of a personal bias, I guess, in my mind, I don't know why in reading this article, I have this idea that maybe intra-abdominal infections are harder to treat, right? Or harder to whatever. And you've seen it or I've seen it where people are on Augmentin and they stay on it for 2 weeks, 3 weeks, and some sort of almost made up regimen despite having source control. And now I think I'm in that patient population personally. I think I'm more apt to just say, hey, you're improving. We have source control. We know what we're doing 1 week and whatnot. And yeah, I agree to your point just briefly on the systems benefit. I had the exact same reaction. I was
Yep.
like, the antibiotic stewardship people are going to be all over this administration, right? Shorter length of stay, less C. diff, less drug exposure, less possible toxicity. I mean, you name it. Um, and to an extent, yes, they excluded staph, but nonetheless, I do think it's exciting and very applicable because staph is not the only infection, of course, as you know, that we see in the hospital.
Yeah. And and there are in theory, I think like our staph epidermidis or and that kind of stuff could have been in there, which is some of our cases. But a lot of times in the study, even they said like a lot of times we say that's contaminant anyways. But if it is actually our infectious organism, then it was included in this trial. Yeah, so I agree, and you're right. You said at the top when you were talking about it, they didn't shy away from sick patients. Obviously, limited it from like immunosuppressed standpoint, or some essentially not having source control, whether it's a valve that's infected or whatever else. Obviously, didn't include that, or your bones infected or whatever, or your joints infected. Like those are different. You don't have source control, but very sick patients from like an ICU standpoint, and very pertinent to our work every day as a hospitalist. And like our first article about the aspirin, that's more like what are we discharging somebody on and going to affect whether or not they come back with a bleed. Whereas this is like very much going to be our day-to-day work of treating bacteremic patients. So I think really exciting. Um, any other thoughts?
Um, no, I don't think so. I think two big articles that I think honestly very impactful from a lot of impact from a day-to-day standpoint. You're exactly right. I think medication errors are something that I personally take into account big time, particularly when I'm consult or co-management. And so I think the first article, I think for me personally, ties into more of that. But this, day to day, offloading our ID colleagues with less consults and being more confident that we can do it, and particularly in these uncomplicated bacteremias, that's exciting as well.
Okay, so I'd say key takeaways from our episode today. When you've got someone with a history of coronary artery disease that's had interventions in the past and is on secondary prevention aspirin, if it's been greater than 6 months, if you need to anticoagulate them, stop the aspirin. That'll improve, essentially reduce their risk of bleeding and overall improve their outcomes. And then if you've got someone with bacteremia that's not Staph aureus and has source control and they're not immunocompromised, 7 days works just as good as 14 days. So we can save people from a lot of home IV antibiotics and PICs and all the complications associated with that. Well, thank you so much, Dr. Ospina. I've really enjoyed having you. I hope to have you on again. Um,
Anytime, Dr. Turner.
yeah, thank you. And to our listeners, if anyone who'd like to be on the show, or if you have an interesting article, if you're a provider or a pharmacist, a nurse, a resident, a student, or anyone with some value added insight in the management of hospitalized patients, just reach out to me. You can text me, message me, or you can email podcast@inpatientupdate.com. If you'd like to be involved, I'd love to have you. So thank you very much for joining us. And this has been Inpatient Update.